Hello everyone. Now I thought it'd be good to do a video on a STEMI from a nursing perspective. Okay, so first of all, you've got a patient presenting with a STEMI. What symptoms are they going to have? They could have chest pain. Cardiac chest pain is very different to pleuritic chest pain. Cardiac chest pain tends to be heavy, crushing, radiating down the left arm, up into the jaw, sometimes down the right arm. But be very careful with chest pain, especially in women and diabetics, because they may not have pain or they may just have mild discomfort. So very important just to be open-minded, that it's not always a textbook presentation of heavy crushing, radiating down left arm chest pain. Another common symptom is increased respiratory rate and shortness of breath. And this could be because the body's just trying harder to get more oxygen around. And they're also anxious as well, which increases your respiratory rate. Often people having massive MIs, they've said they felt like they were going to die afterwards. I had one patient once tell me he thought I was an angel holding his hand, and he was dying. He was going to heaven. Bless him. So yeah, other symptoms include nausea. Your patient will be pale, sweaty, clammy. They may have some of these, not all of them. They may be cyanosed, so they may be a bit blue around the lips. And they could have acute pulmonary edema as well. And you'd know by listening to the chest and hearing the fine expiratory crackles. So, nursing care for these patients. As I said before, I had that one patient once who held my hand and he said, I thought I was an angel. He thought he was dying, going to heaven. He was so anxious and stressed. That's the first thing I thought when I looked at him. I was like, this guy is so scared. He was petrified, because you get this feeling of impending doom. So your patients do need reassurance. Remember the people, we're treating them. So give them reassurance. They need to rest. We don't want to be getting them up to the toilet to have a shower or whatever. They need to be staying in bed. They need to rest. And obviously our patient's going to need a baseline set of OBS. And if someone's presenting with an acute STEMI, you're going to need to repeat those OBS quite regularly, especially if they're compromised in any way. So of course our patient will need a full A to E assessment and a pain assessment as well, using the PQRST algorithm. They're going to need IV access and cardiac specific blood sewing. So we want to be checking for the troponin and CK levels. You check the troponin levels according to the ACS guidelines. You don't need to stress too much about the intervals and the times with that, because it's very dependent on what risk level the patient is and how they present, and that's a doctor's decision anyway. Obviously we need to do an ECG within 10 minutes of presentation, and often the doctor will require serial ECGs. So we need to remember to repeat that as well. In these patients, we usually leave the ECG leads, the dots connected, so we just have to connect the leads back up. In some emergency departments, they'll be connected to continuously to the ECG, so you just need to print one off whenever, and they'll have continuous cardiac monitoring as well. So how do we treat upon initial presentation? Well, there was the old acronym MONA, and it's still really present, just a couple of different things in there as well. It's been altered slightly in the sense that we give oxygen, but only if the O2 sats are below 93%. Obviously, we need to bear in mind if the patient is a COPD patient that we could go lower with that, but again, that's not our decision necessarily. We need to discuss that with the doctor and make that decision, but we certainly wouldn't want to be giving our COPD patient 15 litres non-rebreather if the sats are 93%, because that could be very normal for them. So after the oxygen, you need GTN every 5 minutes. You can give that 3 times if the patient's tolerating it and not dropping the blood pressure too much. If the pain is still not responding, there's no improvement in the condition after 3 lots of GTN, then you could consider a GTN infusion. Again, the doctor needs to prescribe that. So GTN can be the sublingual spray or the tablets, sublingual tablets. Pain relief, it's recommended to give IV morphine or fentanyl. There's a push more towards fentanyl now. And the old aspirin, 300 milligrams, and that's chewed or dispersible aspirin. If you're with a family friend, somebody who you think could be having an MI at home, you can give them aspirin at home. It's going to start thinning that blood out and may just help direct some blood flow back into the myocardium. Clopidogrel is only given now if ACS is confirmed or a STEMI is confirmed. And then we get to the gold standard curative treatment, the PCI thrombolysis. And as I discussed in my previous video, it depends on the patient's individual circumstances as to whether they can have PCI or thrombolysis. In some circumstances, they may have both. I hope this helps clarify a few things with you and just gives you a little bit more direction. As always, I welcome any feedback. Happy studying, guys. Thank you.